This slide series will go over acute care and toxicology. In terms of prevention of accidental ingestions, the AAP recommends for anticipatory guidance being provided at the 6-month well child check. We ask for parents to know the poison control phone number, and we no longer ask them to have Ipecac on hand to induce vomiting. We've also found success with unit dose packaging for medications and with metric dosing. If you assess an accidental exposure to organophosphates, corrosives, or hydrocarbons like lighter fluids, you should start with skin decontamination. If you know about an ingestion that happened less than an hour ago, charcoal can help you for salicylates, digoxin, phenytoin, and amanita mushrooms. You would give this with a large orogastric tube for most ingestions. This would not be helpful for things like corrosives, alcohols, metals, or gasolines, and it's important to maintain your airway or intubate if a patient can't protect their own airway. You would do whole bowel irrigation with polyethylene glycol for any medications that have sustained release or are enteric coated. You might consider this for body packing or for ingestion of iron tablets. You should not do this irrigation method if you're concerned about ileus, bowel obstruction, or perforation. Alkalinizing urine with sodium bicarbonate is used for salicylates and for phenobarbital. Dialysis is sometimes needed for salicylates, alcohols, and theophylline. Hemoperfusion is sometimes needed for theophylline, phenytoin, amanita mushroom, and barbiturates. And then there's a type of immunotherapy that we use sometimes for digoxin toxicity. A commonly tested overdose is of Tylenol or acetaminophen poisoning. This typically peaks at a half an hour to 2 hours with a therapeutic dose and within 4 hours with an overdose. The elimination half-life is between 2 and 4 hours, but if the liver is starting to take damage, then the elimination can be delayed with hepatotoxicity. We'll see toxicity with greater than 12 grams ingested of Tylenol, or if you're using weight-based for a smaller child, you think about 250 mg per kg. Chronic overdose can be seen more insidiously over a period of 2 to 4 days, with doses exceeding 150 mg per kg per day. Children who are younger, less than 6-year-old, are paradoxically less susceptible because they have more vomiting and more glutathione. Chronic overdosing, fasting, and illness associated with Tylenol use has worse outcomes. This is mainly attributed to your inability to use a nomogram for a more acute ingestion, so you would use LFTs instead. On day 1, you're most likely to just see nausea and vomiting. The second and third day, patients will start complaining about right upper quadrant pain, and you'll start seeing evidence of hepatotoxicity with transaminitis. Between day 3 and 5 after Tylenol overdose, you'll see liver failure, encephalopathy, and this is when patients have the highest risk for mortality. By day 5 to 8, you should start to expect evidence of recovery. You would measure the level at least 4 hours after the suspected ingestion. If you're within 4 hours of a known ingestion, you can try giving charcoal. NAC restores glutathione stores if you're above the nomogram line. So if you're above the nomogram, you should give NAC, and then the mechanism is that it's restoring glutathione. You should also give it if you don't have a level, or if the overdose time is unknown or they're presenting delayed and they have any detectable level of Tylenol. You should give NAC orally if possible. This would just be a 3-day course, But if a patient is not able to tolerate oral, as most patients are, you should give it IV. And then if they have evidence of liver failure, then you would give IV as well. The IV course is much shorter. It's only a 21-hour course. 20% of patients have a non-IgE anaphylaxis to NAC. So this is something to keep in mind, that 1 in 5 patients may require allergic treatments for your NAC infusion. Patients that are considered for liver transplant are those that have pH less than 7.3, encephalopathy, if the PT climbs above 100, and if they're showing evidence of renal dysfunction with a creatinine greater than 2.3. Next, we'll talk about salicylate overdose. Salicylates are seen in aspirin, Pepto-Bismol, and oil of wintergreen. Salicylic acid moves across the blood-brain barrier. It can cause tachypnea, hyperthermia, tinnitus, nausea and vomiting, and pulmonary edema. If someone has pulmonary edema, that suggests a need for dialysis. The hyperthermia that salicylates caused is attributed to mitochondrial uncoupling. Salicylate toxicity causes a primary respiratory alkalosis because of the tachypnea. This is helping them though, because the lactic and ketoacidosis causes a primary metabolic acidosis. Hypovolemia, hypernatremia, and hyperglycemia are also seen, and then this hyperglycemia starts to progress to hypoglycemia as the patient deteriorates. You would treat with activated charcoal. You can repeat this until their level is less than 40 and their symptoms are resolved. Those are your treatment goals. You can also alkalinize the urine with sodium bicarb, as we talked about on a previous slide. You would consider dialysis, like we talked about, for patients with pulmonary edema, or if your aspirin level is greater than 100. You would intubate only if a patient is not breathing quickly, so you would not intubate for that tachypnic patient. They are helping against their metabolic acidosis, or if they're unstable, then you might intubate as well. You would give them fluids, D5 with bicarb, and then you would add potassium. The reason to add potassium is that if the patient becomes hypokalemic, it will interfere with your goals of alkalinization. Opioid toxicity causes meiosis, bradycardia, hypotension, respiratory depression, pulmonary edema, and CNS depression. You would treat with activated charcoal and Narcan or naloxone, and you might need repeat dosing of Narcan. Anticholinergics are found in antihistamines, TCAs, eye drops, jimsonweed, and nightshade. The antimuscarinic effects, to contrast with the nicotinic effects that you see with anticholinergic poisoning, are mydriasis, hyperthermia, ileus, urinary retention, and delirium. On an EKG, if someone has anticholinergic poisoning, you might see a prolonged QRS. You will see hypotension and tachycardia on their vital signs, and they could progress to ventricular tachycardia or ventricular fibrillation. These patients can have comas and seizures. The seizure risk is increased if that QRS starts to prolong greater than 0.1 seconds. If it prolongs greater than 0.16 seconds, they have a risk to progressing to a serious arrhythmia. We think about this most commonly with TCA overdose. You would treat this with sodium bicarbonate. Overall, you're treating anticholinergic poisoning with activated charcoal. If you're assessing a life-threatening condition associated with this injury, then you would treat with physostigmine. You could also treat with benzodiazepines for agitation or for any seizures. So the anticholinergics affected just the muscarinic pathways. Organophosphates are cholinesterase inhibitors, so they're going to affect nicotinic and muscarinic pathways. We see this in pesticides, medications for glaucoma and myasthenia gravis, and in older generations, exposure to sarin gas. The nicotinic or muscular effects are fasciculations, muscle weakness, and paralysis. We would reverse these with pralidoxime as a slow IV bolus with atropine. The muscarinic effects, these are the central nervous system effects, are coma, seizure, and respiratory depression. We would reverse these with atropine as well, and we might use benzodiazepines for seizures. For organophosphate exposure, it's important to decontaminate the skin. If it's been ingested within an hour, you can consider use of activated charcoal, but we would not be trying to induce emesis for this ingestion. Hydrocarbons or gasolines mainly cause issues with aspiration. You'll see CNS depression, seizures, and arrhythmias associated with the sudden sniffing death. You'll also see liver and renal necrosis. Patients will initially present with nausea, vomiting, and fever, and on a chest x-ray, because of the aspirations, you might see diffuse bilateral infiltrates. You would observe these patients for 6 hours. For bronchospasms, you might need beta agonists, and patients may need oxygen, ventilation, and even ECMO. For alcohols and glycols, the three that we'll compare are methanol and ethylene glycol and ethanol or alcohol. Methanol and ethylene glycol have toxic metabolites. Methanol can cause blindness, mydriasis, and an anion gap acidosis. Ethylene glycol also causes an anion gap acidosis, but the symptoms look more like hypocalcemia causing tetany and cranial nerve palsies, and then formation of oxalate crystals. Methanol and ethylene glycol can both cause lethargy and CNS depression, similarly to alcohol. We can reverse these effects with fomepizole, which inhibits alcohol dehydrogenase. We can also treat the acidosis with sodium bicarbonate. We can treat with actual alcohol to try and outcompete the methanol and ethylene glycol, and some patients require dialysis. For alcohol intoxication, patients will present at worst with seizures and hypoglycemia, but they will not demonstrate an anion gap acidosis with regular alcohol ingestion. If your alcohol level is greater than 450 mg per deciliter, you would consider hemodialysis for the patient. Sometimes the board exam tests on ingestion of blood pressure medications. An interesting nuance is that clonidine can mimic opioid ingestion, but obviously it would not block the pain response. So if someone has central nervous system depression, bradycardia, and meiosis, but is still responsive to pain, then you might think about clonidine. If there's a patch, you should remove it. If you're within an hour of ingestion, you could use activated charcoal, and if it's swallowed, you can also consider whole bowel irrigation. You would give atropine for bradycardia and also fluids or pressors depending on the blood pressure. Interestingly, you can reverse it with Narcan. Beta blockers also cause central nervous system depression, bradycardia. They also cause diaphoresis. You could similarly use activated charcoal or bowel irrigation for ingestions, and you would reverse these with things like glucagon, atropine, and epinephrine for beta blockers. Calcium channel blockers can cause bradycardia as well. They also can prolong the PR interval. Again, activated charcoal and bowel irrigation is reasonable, and you would consider fluids, atropine, and calcium to reverse these effects. Caustic ingestions can be from a very acidic or basic solution. Severe acids include oven, rust, and toilet cleaners, as well as drain openers. Drain openers can also be very basic. We also see alkalis in detergents. Patients might present with cough, stridor, drooling, wheezing, pain, poor PO, vomiting, and mucosal burns. If you suspect a button battery ingestion, you would get an AP and lateral x-ray, and if it's found to be in the esophagus or the stomach, you would perform urgent endoscopy. For coins, you'll recognize them on a 2-view X-ray. You would repeat this X-ray in 24 hours if the coin is in a proximal location like the esophagus or the stomach and the patient is asymptomatic. But if the patient is asymptomatic or you haven't passed the coin through the stomach in 24 hours, then you would consider endoscopy. For magnet ingestions, you would consider endoscopy if you're seeing that the magnet is proximal, similarly to the coin algorithm. You would also consider endoscopy for ingestion of multiple magnets. You would do an X-ray every 4 to 6 hours instead of every 24 hours if they're asymptomatic and if it's beyond the stomach. You could consider whole bowel irrigation, and some patients require surgery to remove these. Iron ingestion is toxic starting at 60 mg per kg. We think about toddlers who take their parents' prenatal vitamins and teenagers who choose to overdose. In the first 6 hours, you'll just see GI symptoms. You'll start to see more systemic fatigue in the first day. After 1 to 3 days, you'll start seeing evidence of shock and metabolic acidosis. Within the first week, you'll see evidence of hepatic necrosis and bowel obstruction from scarring at a longer term time at 2 to 8 weeks. You would get levels of iron 4 hours after the ingestion. A level of iron greater than 350 is considered severe and is correlated with hyperglycemia, glucose greater than 150, and leukocytosis, a white count greater than 15,000. You would perform gastric lavage or whole bowel irrigation. You can also use deferoxamine to reverse the iron effects. It turns the urine orange, so it's important to let patients know this. You would give this early for a level of greater than 500 if the patient has severe symptoms, evidence of metabolic acidosis, or if you're seeing many pills on your X-ray. A biohazard like anthrax is going to cause cutaneous symptoms predominantly, pruritic papules, central bolus lesion, necrosis, and then this develops into a painless eschar. You'll see a less than 2-week incubation period for exposure to anthrax. Water hemlock, which looks like a parsnip, can cause seizures and status epilepticus. Amanita mushroom toxin can cause liver toxicity because of the cell apoptosis. You'll typically see within 2 to 4 days liver and renal failure, and you would treat this with activated charcoal. This slide reviews the antidotes for various toxins. For acetaminophen or Tylenol, we would use NAC. For pure anticholinergic exposure, we would use physostigmine. For tricyclics, to try and prevent torsades, we would use sodium bicarbonate. For salicylates, to try and alkalinize the urine, we would also use sodium bicarbonate. For organophosphates, we would use atropine and pralidoxime. This is because we're trying to reverse muscarinic and nicotinic effects. For methanol or ethylene glycol, we would use fomepizole. For beta blockers, we would try to reverse these effects with glucagon and epinephrine. Iron is reversed with deferoxamine. Opioids and clonidine are both reversed with naloxone or Narcan. Administration of activated charcoal may be beneficial to a patient who has ingested which of the following: iron, cyanide, salicylates, lithium, or methanol. The correct answer is salicylates. This would also be helpful for amanita mushroom, phenobarbital, and theophylline. A 16-year-old boy presents to the emergency department with vomiting and lethargy. His parents found an empty bottle of extra-strength Tylenol in his bedroom. Which of the following is true about N-acetylcysteine use in the setting of Tylenol overdose? NAC is indicated only if the serum acetaminophen concentration at 4 hours post-ingestion is above the nomogram treatment line. NAC works via a number of mechanisms, including restoring glutathione stores. The oral formulation of NAC should not be used in children due to potential toxicity. NAC dosing should be adjusted for extended release Tylenol ingestions and for patients with a history of alcohol use. The oral and IV form require the same duration of treatment. The correct answer is that NAC works via a number of mechanisms, including restoring glutathione stores. It also prevents NAPQI binding. A 2-year-old girl presents 2 hours after ingestion of an unknown substance. She has altered sensorium with tachypnea, hyperthermia, vomiting, and metabolic acidosis. Her presentation is most consistent with ingestion of which of the following agents? Tricyclic antidepressant, acetaminophen, barbiturates, salicylates, clonidine. This answer is salicylates. So this kind of ingestion can cause tachypnea from direct medullary stimulation, can also cause hyperthermia, tinnitus, direct stimulation of vomiting, and pulmonary edema. And if you'll remember, a patient with pulmonary edema and suspected salicylate ingestion would meet an indication for dialysis. It causes metabolic acidosis and respiratory alkalosis, which is critical to survival, hypovolemia, hypernatremia, and then it causes hyperglycemia first, which progresses to hypoglycemia. These last questions will cover more broadly critical care and emergency questions. A 3-year-old girl presents to the emergency room by her parents for vomiting and tachypnea. On physical exam, she is tired appearing and pale. Vital signs include a heart rate of 170, respiratory rate of 40, temperature of 37 degrees Celsius, and a blood pressure of 78/43. Capillary refill time is 3 to 4 seconds, and her extremities are cool. The liver is palpable 2 or 3 centimeters below the costal margin. The most appropriate next step in the management of this patient is monitor in the ED and discharge if she tolerates oral intake. Administer 20 cc's per kg of normal saline IV. Obtain cardiac MRI to evaluate for cardiac disease. Begin dopamine infusion at 15 mics per kg per min. Endotracheal intubation. The correct answer is to give a bolus. This patient may be in cardiogenic shock, but they still need fluids based on this blood pressure. A 3-month-old infant presents to the emergency room for irritability. His father does not endorse any history of vomiting, diarrhea, cold symptoms, but he says the baby looks pale and doesn't seem as interested in feeding. On exam, his temperature is 37.2 degrees, his heart rate is 240, and his respiratory rate is 45. The baby is pale and not in distress. Lung sounds are clear and the liver is palpable 2 centimeters below the costal margin. Capillary refill is 3 to 4 seconds. The most appropriate first step in management is administer ice to the face, order a chest radiograph, order a liver ultrasound, start milrinone, or consult cardiology. The correct answer for this patient with SVT is to give ice to the face. A 5-year-old girl with cystic fibrosis presents to the emergency room with abdominal pain. The pain is periumbilical and intermittent. She has not had any vomiting, but she has had diarrhea that appears to be a mixture of mucus and blood. Which of the following is true about her condition? Surgical intervention is indicated due to her comorbid condition of cystic fibrosis. This condition cannot be diagnosed by X-ray alone. In children younger than 5 years of age, most cases are idiopathic in nature. Upper GI study is the gold standard for diagnosis. The risk of recurrence is 25% after non-surgical intervention. The correct answer for this patient presenting with intussusception is that most cases are idiopathic in children younger than 5 years old. After 5, a lead point like a Meckel's diverticulum, or in the case of this patient, cystic fibrosis with a fecal bolus is more common. You are caring for a child whose parents often take rescued wild animals into their home. They ask you about the risk of rabies infection from wild animals. Of the following, the most likely animal to transmit rabies to humans is rabbit, rat, skunk, squirrel, or mouse. The correct answer is skunk. You're also at risk for raccoons, foxes, and bats. A 2-year-old girl is admitted to the ICU with second and third degree burns over 30% of her body. She weighs 10 kilograms. What is the total fluid goal for the first 24 hours? 1200, 1400, 1600, 1800, or 2200 milliliters? The correct answer is 2200 milliliters. So in order to get this calculation, you need to figure out her maintenance first, which is 40 times 24. And then you would add this to 4 cc's per kilogram. So 4 times 10 is 40. And then you multiply that times her body surface area to get the second half of this equation. So they gave you 30%. So you do 4 times 10 times 30. That gives you 40 times 30. And then you add that to 40 times 24. And then that gives you 2200 cc's per day. You'd give this 2200 cc's half of that in the first 8 hours, and then you would give the following 1100 over the rest of the 16 hours in the day. That is the last slide for this lecture.